Can you see my slides now?
Yes.
Good.
Look good.
Yes, we can.
Okay, so Catherine, this was really great, presentation that I heard from you, and I'm really glad to see that now clinical research studies are showing the evidence that is really important when we work with clients with comorbid addiction and post-traumatic stress disorder, trauma, that is very important that we include different forms of treatment for PTSD, for trauma, to help clients with this comorbid presentation. And that's our experience starts as well. So I will focus in my presentation on our clinical experiences in addressing this comorbid presentation in refugee clients. So this presentation will cover START's clinical data related to substance use disorder and other mental disorders, and also common issues seen in refugees. Then I will talk about link between trauma, brain dysregulation, and addiction. I will describe some of the common EEG brain profiles that we are now learning about that are linked to addiction, and also their treatment implications. And then as a clinician, I will focus on treatment model that we use in our neurofeedback clinic to address this comorbid presentation. And as an essential part of this, I will quickly describe neurofeedback technique that we use to address brain dysregulation issues that I really believe are underlying both conditions. Looking at START's clinical data that was collected routinely in 2018 and 19, only a small percentage of clients, around 6% of assessed refugees, disclosed substance use issues. And I really think that this is underreporting. If 6% is really smart percentage for, especially for those with complex trauma. And I would expect that this number is really higher. And I believe that some clients are hesitant to disclose use of alcohol or other drugs. Some clients don't even consider this to be a problem. And we just had someone recently who denied having any problem with any substances, but then telling us that he had to drink up half a bottle of wine every night to help him fall asleep. Some clients are not even aware that they have developed physiological dependency on benzodiazepines frequently, and also on opioids for pain management, such as tramadol. And those are some of the big issues that we see in our clinic. Looking from another angle at the same data, we can see that those who have disclosed substance use issues have also disclosed more severe symptoms of anxiety, depression, post-traumatic stress, chronic pain, and complex grief. And that they also have more severe interpersonal and family difficulties, and also they disclose social isolation as a big problem. So looking at treatment challenges associated with this comorbid substance use and post-traumatic stress disorder, from clinicians' perspective, this comorbidity leads to more complicated clinical presentations and poses significant treatment challenges, as Catherine was already telling us. So as clinicians, we are asking questions: where do we start? What do we treat first? How to best prioritize and integrate treatment components? What is the best way to address clients' self-destructive behaviors and also their severe symptoms? How do we handle those who are severely dysregulated? And again, question, should we first focus on trauma or on addiction treatment? Correlation between traumatic exposure in childhood and adult mental health and substance use disorder. Catherine mentioned famous ACE study, Adverse Childhood Experiences study, where this link was confirmed. And there are many other studies later on big samples confirming that across a variety of substances, childhood trauma is associated with problematic substance use. Individuals with childhood trauma histories, and we see often in our clinic those with both refugee and early childhood trauma, they're more likely to report chronic pain symptoms and then to be prescribed pain medication. And this is then increasing risk for opioid addiction. In association to those who had trauma in adulthood, there is less straightforward relationship, but evidence supports, again, mediating role of PTSD in developing substance use disorder across different substances and different trauma types. Conceptualization of PTSD in DSM-5, and especially complex PTSD, have moved beyond predominantly fear response to include dysregulation of a variety of emotional states, the way how there is a problem is in regulating fear, anger, guilt, and shame. And in this context, dysfunctional behaviors such as self-harm and substance use are seen as efforts to regulate autonomic nervous system and central nervous system dysregulation, especially in the face of triggers for past traumatic experiences. And as Catherine said, more in those who are prone to avoid triggers. If the role of substance use is to help regulate nervous system, then the question is, why shouldn't we look for those techniques that can more effectively address underlying brain dysregulation, which is at the core of PTSD and its driver for addictive behavior in those with post-traumatic stress disorder. In our clinic, we use neurofeedback to address underlying nervous system dysregulation before we move into trauma treatment and also in further addressing addictive behaviors. So we'll just briefly touch on EEG patterns that we're seeing in those who have substance use disorder. This is a small pilot study done by Jay Gunkelman and Curtis Cripe. It was only on 30 clients who attended their clinic for treatment of addiction. That was done at the Crossroad Institute in a brain recovery program. This is a program that uses biopsychosocial model of care that includes a core component of EEG assessment that is then informing neurofeedback treatment or medication treatment, and then individualized neurocognitive rehabilitation, nutrition, counseling program. So there are two distinct neural factors that we're seeing as underlying prevalence of addiction, and that what they stipulated is that they likely represent separate pathophysiological drivers for addictive behavior. So what they've seen in a group of 30 clients is that 2/3 of them have some sort of central nervous system overarousal, and 1/3 had cingulate issues, obsessive compulsive drive. So central nervous system overdrive, overarousal was attributed to 3 distinct brain profiles. One is low voltage fast EEG that is also frequently seen in families of those who were alcoholics. Then faster alpha with underlying and basic rhythm of their brain is very fast, or beta spindles. So all 3 represent and are then seen behaviorally as a high level of arousal. So those clients would have a higher level of anxiety, insomnia, agitation, and in these cases, drugs or alcohol were used to reduce high arousal. 1/3 of clients didn't have this profile. They had actually profile that looks more like cingulate-based obsessive compulsive drive. And what they saw is the dysregulation in anterior midline, and that would be excess theta and excess alpha, excess slow activity, or even excess beta, that is excess of fast activity. But what they were explaining is that actually all of them indicate dysregulated anterior cingulate activity of anterior cingulate gyres that is responsible for obsessive compulsive behavior when dysregulated, And it's also responsible for ability to then, in healthy people, ability to shift attention, ability to regulate their mood. And we frequently see this pattern of dysregulated anterior midline frontal activity in clients who are stuck in certain behaviors, those who have obsessive ruminations, and as one of the profiles seen in addiction, actually in this case, we are trying to address this underlying drive and work to re-regulate the activity of the anterior sigmoid gyrus. But there is one potential driver that it was not described in Jane Gunkelman's paper, and that could be third neural factor that underlies cases of addiction seen in those who were addicted to stimulants or compulsive gambling. Impulsivity has been recognized as a characteristic of individuals addicted to drugs, along with sensation seeking and poor decision making. So neural correlates seen include amygdala over-responsiveness to reward and weak control of ventromedial prefrontal cortex. But there is also some research now that is looking into EEG patterns seen in those who were addicted to gambling and those who had high scores on impulsivity. They showed distinct changes in left and right or midline frontocental regions. They have decreased absolute power of theta or alpha or beta, or all three. And in these cases, as in previous cases described with overarousal and obsessive compulsive drive, we have different neurofeedback approaches to address this underlying pathophysiology, and in that way address then and see changes behaviorally as well. You know, we were talking about clients who have issues with use of drugs and alcohol. And traditionally, addiction is treated as a behavioral disorder. But it's more and more recognized also as a brain disorder. And we can look at addiction as a self-regulation disorder, with drugs serving the role of self-medication to help re-regulate destabilized nervous systems, and especially if they were destabilized through trauma. So there is a growing body of evidence that relates to the impact of different drugs on our brain functioning. And I will mention just a few of them. And you might even notice that you might be addicted to some of them as well. That can make us rethink the notion that is us and them. And some of these substances are, as you can guess, first of them, coffee and tobacco. And the reason why we use these drugs is to stimulate our nervous system. Coffee and tobacco are increasing alpha peak frequency, our dominant frequency in our brain, even up to 2 hertz. What is a lot? It means that it can speed up our process of receiving information. And we all know when we take coffee, we feel brighter, we have more energy, we are better focused. And then downside is that when we are withdrawing from the effect of coffee, we actually have reverse effect. We have slowing down of our frontal lobe. So we feel dull, we feel tired, we can't focus, we are foggy. And then we need to go downstairs from our office and get another coffee and then another coffee. And we are probably using some substances, even without thinking that they are influencing our nervous system. And there is another drug that is quite famous drug for university students, those who have exams that are coming, or they need to finish their assignments and they just want to do it quickly. I know about someone in my family who was using Ritalin to get through her honors, but it's really what is interesting about this drug is that actually is effective just for 1 for one type of brains. And those are people who have slow frontally theta, who have excess theta frontally. They are responding well to Ritalin. And even when you think about attention deficit disorder, and Ritalin is frequently prescribed to improve attention, actually it doesn't work for everyone with attention deficit disorder. Those who have excessive alpha frontocentrally, SSRIs is a better choice of drug because it will decrease frontal alpha. So if you're experimenting with drugs, better know your brain. Many of our clients who have suffer from PTSD actually are using cannabis to cope with their symptoms. Unfortunately, with regular use of cannabis, there is increase in frontal alpha and also frontal lobe hypercoherences are seen in alpha. What that really means in terms of symptoms is that there are less and less ability to cognitively function properly. So there is increase in problem with attention and memory, also in the ability to respond appropriately to the situation. And because it's also leading to alteration in sensory gating, we've seen quite few young people who develop psychosis as a result of when they experimenting with dope. I had someone years ago who was in my therapy group who called me one day in panic telling that she's seeing white mice. And I just asked her, what did you take? Are you taking any drugs? And of course that was cannabis. So it got her quickly to our office, and a colleague of mine was seeing her for neurofeedback to help re-regulate her brain. And let's look at another drug that is favorite for many of us at night when we are coming back from work and feeling quite wound up and we need something to calm us down, for some people to fall asleep even. Actually, this is quite a drug that is favored with those who have low voltage fast AG. And those are people who are never able to relax. And we see them among those who are really highly anxious, always on the go. And their brain is not able to produce resting alpha rhythm, even with eyes closed, when our occipital lobe, our visual cortex should idle, and we should see nicely formed alpha with very fast low voltage type of EEG. We don't see their ability to go into that resting alpha state. But when they take a couple of drinks, suddenly alpha appears in their brain and their anxiety goes down. So they quite quickly can get hooked up on using alcohol as a coping mechanism and become alcoholics later on. So how do we address this problem in our clinic? So it starts, we use biopsychosocial model of care. And I will describe the process of treatment for clients who have this comorbid substance use problem and PTSD. And we've been using this approach for the last 18 years in our clinic. So I'll describe briefly just the process of how we start the treatment for our clients and work on their commitment and contract. Then how we use special type of neurofeedback to help stabilize their nervous system and to improve their affect regulation. Then another type of neurofeedback that we use for trauma processing and to work on addictive behaviors. Of course, frequently we see relapse, so how we manage relapse. And then coming from relapse, also, we often see family system issues or deeper emotional problems that we need to address. How we work on addressing values, belief system, and meaning as part of their treatment. What we do to help with relapse prevention so that we can finish their treatment. So initially, although I know that, Catherine, what you said is that it's not necessary to address addiction before we address PTSD. In our clinic, we routinely, when we notice that clients have problems with substances, we refer them to drug and alcohol service. And it's preferably that they are that they go through detox before we start neurofeedback, because it will have a better than ability to train and retrain their brain wave patterns if they are sober and if they're not under the influence of drugs. So commitment is very important for this process. Part of what we do is we always assess brain activity, and looking at all these different patterns and explaining main drivers for use of drug and alcohol is quite liberating, because it takes stigma off. We're talking about this as a coping strategy, that they just spontaneously found a drug that would help them regulate their nervous system, reduce their symptoms, and that now we will try to use neurofeedback instead of substances that they used before to help with this process. And as a first stage of stabilization, when we work on reducing reactivity of their nervous system and reducing affect dysregulation, we use neurofeedback techniques for that. And for those who use neurofeedback, at the bottom, you can see some main protocols that we use in this process. So neurofeedback is most dramatically affecting arousal, and it can quite quickly reduce arousal. That is one of the main drivers for use of drugs and alcohol. Also, it can help with affect regulation, and we work on those obsessive compulsive drives as well. And over time, it resets brain rhythms that translates then into significant changes in symptoms. So just briefly, what is neurofeedback? It's a modality of biofeedback. It's a training for brain, where we, in this process, when a client is sitting in a recliner, we attach sensors to the skull. We use neurofeedback protocol based on what we see in EEG and symptoms, and then actively they are getting feedback of what is happening in their brain, and they can retrain or remodulate their brain arousal through either reducing frequencies that were more prominent there and that has calming effect. In some cases, we need to increase some frequencies in their brain to get more of a stimulating effect, similar to what you get with drugs. And after a while, results are permanent, and there is permanent change happening in the brain that then is reflected in their behavior, reduction in symptoms. So in this, on the screen, you can see this is a game that they can play, where middle rocket, this green rocket, is the one that is representing stable brain waves, efficient brain waves, usually middle range. That means you're calm, you're relaxed, but you're focused. And it's discouraging brain to produce really fast frequencies, those that are seen in hyperarousal, or very slow frequencies that are seen frequently in clients who have also dissociative symptoms. And over time, it's really reshaping and modulating brain to stay in that calm, relaxed, and attentive states. The other modality that we use then, once when clients are stabilized for trauma reprocessing, is called alpha theta training. And it's a quite deep meditative training, where again, we attach sensors and measure brain activity, and we are encouraging production on alpha and theta brain waves. We start this modality of treatment with guided relaxation and visualization of desired outcomes, especially about those how to withdraw from taking drugs when triggered. And then around 40 minutes with eyes closed training to put them in a really deep meditative state that is really good for reprocessing trauma, but also encoding new messages around their attachment to drugs and the use of drugs, and finding healthier strategies that can address when they're feeling overly aroused, when they're feeling triggered, so that they don't need to use drugs to modulate their behavior. And of course, in this, role of therapist is very important as someone who is holding the space and helping with the process, especially when we are, after training, reprocessing their memories that resurfaced. But because it's their access for lower level arousal, we actually can process quite experiences that are quite traumatic without them being overly aroused. Often what is happening is that as everything goes well and you think treatment is progressing, so you'll finish soon, that they have a relapse. And I see that as a positive sign. Actually, we can then see some other problems that we couldn't see before that they're also driving their addictive behaviors. For example, someone whose family was all family members there for years, helping client who was addicted to heroin. And once when he stayed off drugs and he was really improving, family started falling apart. And he went back to take drugs because he was the one who was keeping them together. So we had to, in that case, address family problem and family system so that client can continue with his treatment. And we often have other reasons why clients go back to test, almost like, let's see if I kept this control. And I really find that it won't take long to get them back on track, but they will have this experience that they can start and stop without becoming, again, addicted to substances, regardless is it drugs or alcohol. Once when they're really stable and when we address those deeper issues that were driving their addiction, then we work on helping them reconnect with their family, with others, develop that sense of belonging that is very important, working on their system of values, helping them to orient themselves towards future. So it's quite a holistic approach that we generally use at STARTS. And then at the end, it could be beginning as well. To help actually with relapse prevention, it's very important to address lifestyle. And we have the whole team working with helping clients exercise, have proper diet, also help them with sleep hygiene, developing different strategies for stress management, and keeping them socially active. That at the beginning, when they're under influence of drugs, that they're still highly traumatized, it's very hard to actually work on changing lifestyle. But I find towards the end of treatment, it's actually a good time to introduce these as strategies that they will use once then they're discharged from our program. Just very quickly, this is one of the clients with complex developmental trauma and substance use. He was using alcohol. He had this very fast profile, frontocentrally, fast activity. He underwent neurofeedback treatment with both neurofeedback modalities and narrative therapy as well. After 34 sessions, we can see now frontally there is no marker anymore for hyperarousal. And we can see that even speed or frequency is slower now than it was when he started his treatment. And just to conclude, there is a really strong relationship between addiction and PTSD. We use in our clinic at STARTS integrated biopsychosocial model of care and stage-oriented approach. I would like you to think about neurofeedback as one of the neuroscience-driven approaches, but also we never forget the role of therapists and trauma-informed therapy in supporting clients' recovery. Thank you for your time.